Welcome back, and let's move to the next segment. Now, our focus will be on another new emerging area in the field of diabetes, and perhaps has the potential to change the way we treat our patients who live with type 2 diabetes. Can diabetes be put into remission? To commence the perspective section, the segment, it's my pleasure to invite the two moderators, Dr. Prasad Katulanda and Dr. Sivatharshya Pathmanathan, consultant endocrinologist from National Hospital of Sri Lanka. Over to you, Madam Mense.
Thank you, Harsha. So I think we are getting into another quite a new and perhaps a controversial area, and also which will tell us, I think, at the end of the this talk, I think we'll be able to see whether we should be treating for failure or whether we should treat him for perhaps a cure or remission. So the very pertinent topic, and actually I was quite fascinated to be chairing this session because one thing is that the topic is quite close to my heart, as well as the speaker had been working with me in the Oxford Center for more than 4 years. Again, a very good friend. Let me hand over the mic to introduce the speaker to Dr. Sivatharshya.
I'm really privileged to introduce our speaker, Dr. Pamela Dyson, BSc Human Nutrition and Dietetics, and also she holds a PhD. She is the academic research dietitian at Oxford Health Foundation NHS Trust. This is a pre-recorded session, and over to you to relay the topic now.
Good afternoon, everybody. I'd like to start by thanking the sponsors and the organisers for inviting me to speak to you today. And I've been asked to talk about diabetes remission, the wave of the future. My name is Pam Dyson, and I'm a research dietitian based in Ockdem in Oxford in the UK. Here's my disclosure slide. I'd just like to draw your attention to the fact that I'm a member of the NHS England SACN Diabetes UK Working Group, which is currently investigating the role of low carbohydrate diets and type 2 diabetes. I've been asked to tell you this because I'd like to say everything I'm talking about today represents my personal views and not that of this committee. So let's get on with the presentation. And as I said, I'll be talking about diabetes remission, and I've divided my talk into 4 main areas. So let's start with some background. So the first question I think we need to ask ourselves is diabetes remission possible? Because type 2 diabetes is generally seen as a progressive and incurable disease. And if we look at data from the UK PDS, this demonstrated a continuous decline in beta cell function over time, and this was irrespective of whether people were receiving glucose-lowering therapy or not. So you can see from the 2 graphs below, the open circles are the intensively treated group who are receiving metformin, insulin, and or sulfonylureas, and the closed circles are the conventional therapy group who were given dietary interventions until their glucose reached a certain level when they were given rescue therapy. But even so, no matter how intensive the treatment, you can see in both cases that both fasting glucose and hemoglobin A1C increased over time. So that lent weight to the argument that in fact diabetes is a progressive disease. However, having said that, we know over the past few years that a number of studies have demonstrated that diabetes remission is possible. But firm conclusions and therefore translation to clinical practice at this stage are limited because most of the studies just had small numbers of participants. There were varying lengths of follow-up, but most studies were short-term, and there's a lack of consensus about the definition of remission. And I'd just like to talk a bit more about this because it's a very important factor. So let's talk about the definition of diabetes remission. And the trouble is at the moment is that we have many different criteria for defining remission, and the 3 that are most commonly used are the Buchholz criteria, and historically these were used to define remission in studies of bariatric surgery. There's the ADA criteria, which distinguishes between partial and complete remission, And then the Association of British Clinical Diabetologists, or ABCD as they're known, have also produced a criteria. And I'm sure none of you will be surprised to hear that they all differ from one another, and there's no general agreement about what diabetes remission actually is. However, having said that, an international group has been meeting to try and agree a consensus definition of diabetes remission, and I think it's very telling that here we are 4 years on and we still don't have any agreement about the criteria for diabetes remission. Apparently they're nearly done, and they have prepared a statement that will be published jointly in Diabetes Care, Diabetic Medicine and Diabetologia within the next 6 months, so look out for that. So hopefully by the end of this year, or certainly in the early months of next year, we should have a published, agreed definition of diabetes remission. But why has it taken them 4 years? I think that's a very good question. And what they've discussed really are 3 aspects: glycemic status, duration and medication. So let's look at glycemic status first. So most people are familiar with the cutoff for diagnosis of diabetes at 48 millimoles per mole. And normoglycemia is less than 42 millimoles per mole, but we've got this grey area in the middle, which is marked as orange on this graph, which is usually called pre-diabetes, and includes both those with impaired fasting glucose and impaired glucose tolerance. And there's a big discussion about where the cutoff should be for diabetes remission. Should it be below 42? Because we know below 42 millimoles per mole there is normoglycemia and no evidence of any risk associated with hyperglycemia. Having said that, we also know that the agreed definition for the diagnosis of diabetes is 48 millimoles per mole. So some people would argue for 48 and some people would argue for 42. I think it's more likely the consensus agreement will be 48 millimoles per mole, simply because that is the diagnostic criteria for diabetes. But there is much discussion about this area in the middle, simply because people in this area are more at risk of both diabetes and cardiovascular disease. So the second issue is duration. So how long do people have to be in diabetes remission before it counts as remission? And if we look back to the criteria I've already mentioned, the Buckle criteria has no time specified. Just one test below a threshold was counted as remission. For the ADA, either partial or complete remission only counts if it's been there for a year. For the Association of British Clinical Diabetologists, they said 2 tests are needed at least 6 months apart. And the direct study, which provides the strongest evidence for remission, used the criteria of 2 tests 2 months apart. So there is a difference between all these criteria and no general agreement. I think it's highly likely that the new criteria that should be published soon will probably say somewhere between 3 to 6 months. But as I haven't seen the document, I don't know what it will be. So at the moment it will probably be 48 millimoles per mole and below for at least 3 to 6 months. And then there's the issue of medication. Now, interestingly enough, this seems to have generated the most discussion amongst the expert group. Most definitions at present agree that all glucose-lowering medications should be stopped, but I believe some members of the group made a strong argument for including metformin because it has properties other than glucose-lowering. So if, for example, a woman with polycystic ovary was taking metformin, then that is not a glucose-lowering agent in her case. So diabetes remission, if she had it, could be diagnosed even though she still continued to take metformin. I think it's likely, in the interests of clarity, that the end criteria will be that diabetes remission is only present if all glucose-lowering therapies, including metformin, are discontinued. So it would be really nice to have a remission criteria that we could all agree on, simply because the studies tell us very different things according to how they've diagnosed diabetes remission. So let's look at the evidence from these studies. So first of all, I'd just like to ask what predicts diabetes remission, and certainly the strongest predictor of short-term remission is weight loss, and I'm sure that's no surprise to anybody that weight loss is very strongly associated with diabetes remission. However, the work that Roy Taylor's done in Newcastle has also shown us that if remission is sustained, it's dependent on normalising the beta cell function. And that is, weight loss is associated with loss of fat from both the pancreas and the liver, and that seems to help regenerate the beta cells. There are other factors too, including the duration of diabetes, baseline hemoglobin A1C, baseline fasting glucose, medication and older age. But these are actually surrogate measures for how long somebody's had diabetes. So those who've had it longer, who had a higher baseline hemoglobin A1C, a higher baseline fasting glucose, who take more medication and who are older, are less likely to achieve diabetes remission. So we know that diabetes remission is more likely in those who have been diagnosed more recently, and that the longer people have had diabetes, the less likely they are to achieve remission. So let's look at the evidence from the study, and I'd like to start with bariatric surgery simply because this offers the strongest evidence for diabetes remission. And if we look at the meta-analyses, on average they report mean BMI losses of about 13.1 kilograms per metre squared, which equates to about 20 to 30 kilos weight loss after about 5 years. They also report greater rates of diabetes remission compared to medical interventions. So a recent meta-analysis has reported that over a third of those receiving bariatric surgery are likely to achieve diabetes remission, compared to less than 2% of those with a medical intervention. And also there is a differential according to the kind of surgery. So bypass surgery has higher rates of remission if you compare it to adjustable gastric banding. But it's really important to remember that remission rates decrease over time. So if we look at a meta-analysis published in 2015, although diabetes remission was about 70% at 1 year, recurrence happens. So diabetes reappears following remission. And in this study, 26% showed recurrence at 3 years, just under 26% at 5 years, and just under half at 8 years. So it appears that over time, diabetes reappears despite initial remission. And the graph below shows data from the Swedish obesity study, which was not a randomized controlled trial, but which reported remission in people who'd had bariatric surgery. And what this shows is at the end of two years, the column in blue, which is the surgery group, reported over 70% remission. But by 15 years, this had dropped to about 30%. So although initial rates are high, they do fall after time, and diabetes does seem to recur in those who initially achieve remission. So to summarise what I've said about remission and surgery, diabetes remission rates of approximately 70% are reported within 1 to 2 years of surgery, and this is associated with weight loss. Gastric bypass surgery is more effective than banding, but there are high rates of diabetes recurrence, about 50% at 15 to 20 years follow-up. And unsurprisingly, recurrence is associated with weight regain and also baseline glucose and insulin concentrations. So let's move on to lifestyle. And I'm just going to present some data from the Look Ahead study. Now, the Look Ahead was not a remission study. You probably remember it was about improving glycemic control and reducing cardiovascular risk in those with type 2 diabetes. But these data I'm presenting here are from a 4-year observation analysis of over 5,000 people who took part in the Look Ahead trial. And the diabetes remission in this trial was defined using the ADA criteria. And if you look at the graph, you'll see the columns in blue. These are people who had intensive lifestyle intervention, which was basically healthy eating, a low-fat diet, and increased physical activity with weight loss. At the end of the first year, just over 11% had achieved remission, and this had fallen to 7% by the 4th year, and compared to about 2% in the control group. So this shows that there are interventions which are generally acceptable and which can produce diabetes remission in usual practice. But it's important to note here that in both the intensive lifestyle intervention group and the control group, that weight loss was what predicted diabetes remission in this study. We also have some evidence for remission in the Mediterranean diet. This was a small study, with 215 people who were newly diagnosed and were randomized to either Mediterranean or a low-fat diet. And they were followed up for between 6 to 8 years. And what the graph shows us is those in the black columns who were receiving the Mediterranean diet, 15% achieved remission at the end of the first year. And by year 6, this had fallen to 6%. But even so, some evidence of diabetes remission using a Mediterranean diet. And then the most robust evidence for diabetes remission comes from a study called DIRECT, which most people are familiar with, but which I'll run through briefly in case you're not. So this study took place in the UK, and it tried to assess whether effective weight management, which was delivered in the primary care setting, so although this was a randomized control trial, they tried to translate it to usual care. They wanted to see if this strategy could produce sustained remission of type 2 diabetes. So if we look at the methods, people who've been diagnosed with diabetes within the past 6 years and who were treated by medication other than insulin were included in the study. They had to be overweight and aged between 20 and 65. They were recruited through general practice and then randomized to the intervention or to best practice care by guidelines. And if we look at the protocol, you'll see that just over 300 people consented, and of those, 157 were allocated to the intervention group. And the intervention consisted of total diet replacement for 3 to 5 months, but for at least 12 weeks. And total diet replacement was soups, shakes and bars, so no food at all, just soups and shakes. They then had 2 to 8 weeks of structured food reintroduction, so they could learn to eat a healthier diet. And then they were given weight maintenance support for the next 2 years. And the control group were allocated to best practice care by guidelines. So they followed the usual care in the area they were for those with type 2 diabetes. And if we look at the results, first of all, let's look at the change in weight and the change in hemoglobin A1C. So the intervention group on the left and the control group on the right. And at the end of 2 years, you can see the intervention group had lost a mean of 7.6 kilos, and hemoglobin A1C had reduced by 5 millimoles per mole. There was a small but insignificant weight loss in the control group, no change in hemoglobin A1C, and in the control group, a small but insignificant increase in medication, which contrasted with the intervention group where there was a significant decrease in medication. And you can see that in all cases, in weight, in glycemic control and in medication, there were statistically significant differences between the two groups in favour of the intervention group. But of course, this trial wasn't just a weight loss trial, it was about diabetes remission. So if we look at remission, and in DIRECT, it was defined as a hemoglobin A1C below 48 millimoles per mole after at least 2 months of all anti-diabetic medication. You can see in the intervention group, 36% at the end of 2 years were in diabetes remission, and this was down slightly from 46% at 1 year. And in the control group, 3% were in remission at the end of 2 years, compared with 4% at the end of the first year. And this was highly statistically significantly different between the two groups. So in conclusion, DIRECT, which was a primary care-led weight management program, resulted in sustained remission at 24 months for more than a third of people with type 2 diabetes. And diabetes remission, you won't be surprised here, was related to the extent of sustained weight loss. But I think it's really important to remember that not everybody who achieves 15 kilo weight loss achieves remission. So just under a third of those who managed to lose 15 kilos did not achieve diabetes remission. And we have questions about how an intervention like this, which is fairly intensive, can be translated to standard clinical care. So that's what I want to talk a bit more now, the translation to practice. So if we're going to replicate the results of DIRECT, what we need is to identify people with type 2 diabetes who've been diagnosed within the last 6 years, because we know that people who've been more recently diagnosed have a greater chance of remission, and they need to be treated by agents other than insulin, because we don't have an evidence-based algorithm for insulin adjustment in those who adopt this strategy. They also need to have a weight management program which incorporates 12 to 20 weeks of total diet replacement, so that's soups and shakes. And that does have a cost implication. Also structured food reintroduction and supported and monitored ongoing weight management. And in the case of Direct, this was monthly 30-minute appointments. So that does have resource implications for primary care. Also, I haven't mentioned this before, but Direct introduced structured rescue therapy. So those who continued to gain weight during the study were offered either partial or total meal replacement again, and the option of orlistat if they wished to take it. Interestingly enough, very few people seem to be keen on the idea of taking orlistat, but about, I think, between 20% and 25% of those needed some kind of rescue therapy because of weight gain. So how's this going to work in clinical practice? Well, in the UK, from September the 1st this year, the National Health Service has introduced a year-long pilot programme for 5,000 people with newly diagnosed type 2 diabetes. So there are certain pilot areas in the UK, unfortunately Oxford is not one of them, which is introducing this in order to try and induce diabetes remission in general practice. So the programme, as did Direct, aims to support weight loss and remission, and it consists of 12 weeks of total diet replacement. And it's interesting to know that this is going to be funded by the NHS. As I've said before, these products can be quite expensive. There's also supported food reintroduction and then weight loss maintenance, so that at this stage increased physical activity will be introduced. If this proves successful, it will become part of routine clinical care, but of course the study's only just started, so we're going to be 2 or 3 years down the line before we know whether or not this is an effective way of achieving diabetes remission in primary care. So are there alternative strategies? Well, I've been working on a small study here in Oxford called the Diamond Programme, and if you look at Direct, to use the total diet replacement and the support for people to maintain their weight loss, it costs, to maintain a weight loss of about 10 kilograms at 1 year, it costs about £1,200, which is a lot of money. So we wondered whether there was an alternative that involved real food, but that again could be delivered in primary care. So we devised a pilot study. So this is a small study with only 30 people. We took people who'd be diagnosed with type 2 diabetes and a BMI over 30 kilograms per metre squared, and we excluded those treated by insulin, as did Direct. We also excluded those with using SGLT2 inhibitors simply because we were using a relatively low carbohydrate diet, and there is evidence in the literature of euglycemic DKA associated with the use of low-carb and SGLT2 inhibitors in people with type 2 diabetes. So the intervention was a food-based diet which provided a similar energy to that from Direct and less than 100 grams of carbohydrate. And the reason we restricted the carbohydrate was simply because at low levels of energy intake, protein has to be maintained. And so something has to go, and in this case it was carbohydrate. We also incorporated a behavioural programme with elements that have been shown to be effective for weight loss. We had a control group, because this was a randomised controlled trial, who received best practice care by guidelines, and we also gave them Diabetes UK information booklets about diet. And they were followed up for 12 weeks. As I said, this was a small, short-term pilot study. And here are the results. So in the left-hand box is the weight, and in the right-hand box, hemoglobin A1C. And if we look at weight change, the control group lost 2 kilos and the intervention group 9.5 kilos. For hemoglobin A1C, there was a small, insignificant reduction in hemoglobin A1C in the control group, but a very significant reduction of 16.3 millimoles per moles in the intervention group. And when we looked at diabetes remission, we saw that about 20% of the intervention group had achieved remission compared to nobody in the control group. Now, this differed from Direct because it wasn't really designed as a diabetes remission trial. It was more a feasibility study to see if people would accept low levels of energy intake delivered through food. So we were very encouraged that it worked from that point of view, and also encouraged that there was diabetes remission. Some of the people in this study had had diabetes longer than 6 years. So we found that a food-based, low-energy, low-carbohydrate intervention was acceptable to adults with type 2 diabetes. All those who were offered the intervention adopted it, and everybody lost weight, although obviously some people lost more weight than others. We found that greater weight loss and remission was reported in the intervention group, and we've now put in an application for a full randomised controlled trial. So if I can summarise what I've said over the past 20 minutes or so, I think we now have robust evidence from randomised controlled trials that both bariatric surgery and lifestyle interventions are effective for the remission of type 2 diabetes. However, at the moment, I don't think we can translate this to standard clinical care. But with emerging evidence, hopefully, remission strategies may be routinely offered to those with newly diagnosed type 2 diabetes, with the hope that some of them at least can achieve remission. Thank you for your attention.
I think it's the time for questions. Have we? So I think it's a recorded talk, and there won't be any questions. Yeah. So I think it's a very good area we all should think about, because it might change at least the way we manage newly diagnosed patients. But things I think few things I would like to touch was predictors. I think things like even checking GAD antibodies, because we might otherwise miss patients with LADA and so on, things to think about. And also I think in our population, particularly the last one she talked about, the Diamond Project, might be relevant. And in my practice at least, people don't like shakes too much. So this is, and also the cost. So these are the things that we need to think about in our setting. And let me hand over to Dr. Sivatharshya to have final comments and conclude.
And the other concern in the South Asian population is our diet is mainly carbohydrate based, and we take a lot of calories. So cutting down and then carrying it for a long time, when you consider remission, is again a concern in our part of the world. So we have to think about it on a long run, and at least if some of our patients can go into remission, that will be great. Although the speaker is currently not with us, I would like to thank her and probably hand over the mic to the organizers for the next session. Thank you.